It's a great pleasure to be part of the Young Ophthalmologist program again. I'm going to talk to you this morning about incisions and AVDs. I have no financial interest in this talk. Cataract surgery begins and ends with the incision, which is why it's so important to get it right. So what makes the perfect incision? Well, first of all, you should be able to match your instrumentation to minimize leakage. You need to have the ability to make a consistent wound architecture in a simple manner. And it should be of sufficient size to allow the surgery without any enlargement or distortion. And then an ability to seal at the end of the procedure. And also that it does not induce astigmatism. What are the factors which may influence the production of an incision? The position of the incision, whether it's superior or temporal, the architecture of the incision, depending on how many planes you create, the size of the phaco tip and sleeve, size of your side port instruments, the knife design and material, and also the size, design and delivery technique for your intraocular lens. So there are many positions for the incision. They can be scleral or limbal, near corneal or corneal, can be superior, oblique, temporal or on axis. And all of these will have an effect on how the incision will behave during the surgery. Here are some common incisions. On the upper left you can see a clear corneal incision. On the upper right a scleral tunnel incision. And then down below a near clear incision which just goes through the edge of the limbal arcade. So how do corneal and scleral incisions compare? Corneal incisions are easier to perform, they're quicker to perform, they're more likely to vary in length, they leak more easily, they're easier to distort, and they may induce more astigmatism. Scleral incisions, on the other hand, take longer to make, may require more than one knife, are more likely to have a consistent shape, but they're less easy to distort, and they induce minimal astigmatism because they are further from the visual axis. Let's have a look at the incisional funnel and the proximity to the visual axis, and this applies to clear corneal, near clear, limbal and scleral incisions. You can see the funnel without any incisions on the left. In the middle you can see that the closer you get to the visual axis, the narrower your incision can be without inducing a lot of astigmatism. However, if you go outside the funnel, you'll get gape and induce much more astigmatism. In this talk, we're largely going to speak about clear corneal incisions. Now, these are by far the most commonly used, but we mustn't forget the side port, which is always corneal. The side port should match the instrument going through it to avoid leakage, but also distortion, and that is why I prefer a trapezoidal incision so that your instrument can move sideways without creating this distortion in that little wound. It also avoids leaking, as you can see in the bottom left picture. I designed the Fat Boy chopper, which is the same size as my bimanual irrigation aspiration, which fits through this incision with minimal leakage. So what cross-sections were we aiming for in our clear corneal incisions? In 1992, in Ocular Surgery News, Howard Fine reviewed clear corneal incisions, and he showed pictures of a single plane incision on the left, a three-plane in the middle, and a Langermann hinge on the right. In fact, this representation is not the way that these incisions perform, as you'll see later on when we look at the OCTs of the wounds. What is the best aspect ratio for a wound? In 1994, Paul Ernest, in this study on cadaver eyes, found that if he had square incisions that were 3.2 millimeters by 3.2, they were extremely stable, with external pressure of 525 pounds per square inch. If you did a rectangular incision that was 3.2 by 2, then this would start leaking at 13 pounds per square inch. The problem is that if the wound is large and near the visual axis, you will get distortion, and this will make your surgery much more difficult. It's much less of an issue when you get to more narrow incisions. So what may happen when wounds are the wrong shape? First of all, we have a wound that was too short. This is one of my trainees operating. You'll see what happens when she does the hydrodissection. The iris prolapse is out. We now need to try and get it back in, and that means that you need to decompress the wound and not inject more viscoelastic. I opted to take over at this point. We closed the wound and I moved superiorly to deal with this dense cataract. This is the very next case by the same surgeon. This time, in order to avoid it being too short, it becomes too long and too close to the limbus. It means that the wound actually goes out into the conjunctiva, and you'll see what happens. As soon as the phaco probe goes in, the conjunctiva starts to balloon. Now what you should do at this stage is come out and immediately make a small peritomy. But she doesn't do that. I was actually out talking to the theatre sister at the time, and this makes surgery much more difficult. Now she's got to deal with a situation where it's almost like operating at the bottom of a swimming pool. But in fact, you'll see in time that this will decompress very quickly if you just wait and give it a little bit of massage. Let's have a look now at some of the inconsistency of shape and length you can get with standard blades. You can get epithelial gaping, endothelial misalignment, local detachment of Descemet's membrane, and the most important is a loss of coaptation where the wound really hasn't sealed properly at all. And all of these are essentially due to the fact that the construction of the incision has been faulty. Different blade configurations and materials produce different incisions, as we'll see in a moment. We're now going to see three single bevel knives. The first is an Alcon single bevel knife to make a 1.8mm incision. This is very thick at the front end, and you'll see that we lose control of the incision and it just shoots in. With a diamond knife, which of course is very sharp, there's a scalloped entrance to the cornea. After that, things improve, but again, the sealing of this incision, which is single plane, is not going to be so good. And here we can see the sharp point trapezoidal knife, where there's initial resistance, which is then lost after the shoulder on the blade is passed, and loss of control. And then it just snaps into the eye. And here's a dual bevel knife, which gives a scalloped entry also, and very poorly controlled construction. I didn't like any of these knives, so I designed my own, having been very frustrated by getting the big knife manufacturers to make the knife that I wanted. It was specifically designed for a multiplane incision. It's called the Windsor knife. It was single bevel, minimal front end resistance, gradual increase in feel, and it has a facet at the front which enables you to judge how far into the eye you've gone and acts as a measuring mark. It also has a blade stability device because this knife is made from flat stock steel, not eroded wire, and it means it's extremely thin, and which is one reason why it has such good control as it goes through the cornea. So let's have a look at wound construction using the Windsor knife. You tilt back first of all to point towards the dome of the cornea. When you get to the measuring mark, you dimple down and go forwards. And let's see it again, this time with an eye that has some trypan blue in it, and you'll see the nice incision that you get. We'll be looking at these again with OCT, so you can see the way that they're actually constructed. We did a study looking at 30 consecutive incisions using anterior segment OCT, and the incision length only varied by a very small amount, plus or minus 0.12 of a millimeter. And the range overall was 1.51 to 1.92. If you look at the profile in cross-section, you'll see that 97%, or basically 29 out of 30, had a three-plane construction. The remainder was two-plane, but that's mainly because there was a loss of some epithelium here. But this wound was extremely good at self-sealing and didn't require any extra hydration for it to do so. Some have claimed that the incisions that you can achieve with a femtosecond laser are actually better. And Michael Lawless in Sydney, who makes a reverse trapezoidal incision that was 2.3 millimeters by 2.6 millimeters, said that he only had to hydrate 50% of the time compared with 100% before. Well, as you will have heard, I don't routinely do this with the incisions I can create with my steel knife. In Stephen Slade's incision study, he looked at Langermann incisions and also dimple down incisions and compared these to his femto incisions. With the Langermann incisions, he said it needed 94% hydration, 87% with his dimple down incisions, but 0% with his laser incisions. So how does that again compare with my Windsor knife? In a study looking at the histology of incisions made with a knife or with a laser that was done by Tom McConan and his group in Frankfurt, he found that in fact the knife incisions produced a much smoother edge, whereas the laser had a much more jagged edge, which may be one reason why some people have found that they don't like to use the laser incisions, they prefer a knife, despite what Slade and Lawless have suggested. So in summary, a perfect incision is easy to make with the knife of your choice, needs to be consistent in architecture and dimensions, self-sealing without hydration, resistant to distortion immediately post-op, and may not require a $500,000 machine.